This is going to be a really great session, and I say that maybe a little biased because Dr. Joe and I worked on this together. But as I mentioned, I've been in the myeloma space since 1991, and over the years I've had the opportunity to hear a wide range of questions, and questions that are really important to the myeloma experience coming from patients, which is why I've developed a new nurse navigator role at Mayo Clinic to help people understand their diagnosis, expectations of the medical visits, their referral to Mayo Clinic, things of that nature. And so today what we're going to do is have a sort of a little back and forth conversation, Dr. Joe and I. We're going to be talking about, some of the questions, frequently asked questions that come up on this myeloma journey. You've met both of us, so I won't go through all of that list of stuff and junk. You know who you are?
I hope so.
Yeah?
Maybe not by tomorrow night, but yeah, right now I'm still good.
But one of the first questions that comes up with patients is they will say, I've never heard of this diagnosis before. How common is this?
So it's a valid question, and whether you've had myeloma for a long time or not, one of the things we hope to get out of this session is to equip you to be able to answer other people's questions. So it's not just so you know the answer, but being able to frame it for someone else. So when we think of myeloma, it's not a very common cancer. It accounts for about 1% to 2% of all cancers. We see about 36,000 new cases here in the US this year. Tragically, about 13,000 people will die from myeloma in this year, which makes us so passionate to work towards it, although the numbers do change, thankfully, over time. And we do know that there are certain things that put you at greater risk of myeloma that I know we're going to talk a little bit about in a moment, but we do see differences by race and gender. So I'm going to give a talk tomorrow on health disparities in myeloma and specifically what we at the IMF have done and are doing to try and help reduce that disparity. Because if you're, like myself, of African descent, you're going to have twice the risk, unfortunately, of developing myeloma. But also we know that myeloma is more common in men than women. And then lastly, that the average age, and of course average is a weird thing because it's a huge spectrum, but the average age of myeloma is about 69. We're going to see, as I describe tomorrow, that it's considerably younger in patients of Latino American background or African American background, but the average is about 69.
Well, and then of course comes the next question, not only how common is it, but how did I get this? What causes myeloma?
Yeah, so for the vast majority of patients, we really do not know, right? You did not earn myeloma, sadly, in that respect, in the sense that there isn't something that we know causes it. We're going to be hearing a little bit about, over the course of this weekend, some of the research and work we're doing. This incredible program in Iceland, where we've screened 90,000 individuals and we're trying to match and understand, is there something in our inherent genetics that puts it at risk of it? But for the overwhelming majority of patients with myeloma, we don't have a reason or a cause that we know can connect them to their myeloma. In a small fraction of patients, we know that there are certain things. So some of our veterans that have been exposed to Agent Orange, firefighters that have been exposed to multiple fires. We did, actually, as the IMF, we looked into the incidence of myeloma in first responders after 9/11, for example, and there was a slight increased risk. But then, of course, there are other things that we can control, like our family history, our race and ethnicity, as I've already commented on. And so, again, we still don't fully understand it. When someone gets diagnosed with myeloma, we don't say, okay, we got to test all of your family members like we do with certain cancers. But we sometimes are in situations where there are multiple family members that have been diagnosed with myeloma. We don't understand the genetic pattern of that yet. We're studying it and trying to understand it. But there may be some situations in which we'll say, maybe we should test. I was in clinic not long ago where someone came in and 2 of their siblings had myeloma, and they had myeloma. So you have 3 siblings with myeloma. There were 5 total. The other 2 wanted to get tested, and I think that's very appropriate. But that's obviously a very unusual situation. But as you've listed here in the slide, Teresa, in most cases, we just don't really know what causes myeloma.
We know that it arises from the bone marrow. The bone marrow is a very important component of our body. Can you help us better understand what the bone marrow does and explain it to me like I'm a 21-year-old?
Yeah, at least you said 21, which means your legal drinking age. So some of you have heard me use this analogy before. People use different analogies in different places. I was teasing Dr. Gertz at our last patient family seminar in Minneapolis that he always talks about the garden. And I'm like, well, he's got a garden, I've got a vineyard. So let me talk about the vineyard analogy. So when you think of what goes on in your blood, so your blood is circulating through you right now. That is the coolest, having the dog right there. I love that, by the way. I just got to say, I was like, he's just taking it all in. I love it, or she. When you think of your blood as circulating right now, it's made of two bits. There's the liquid part, and there's the solid part that's inside it. The liquid part we call the plasma, and that's kind of what carries things, and there's some proteins and so on in it, but it's mostly liquid. And then the solid stuff are what we call your cells. These are the circulating cells. And you have three kinds of cells that circulate in your blood. And I like to think of them as the picture is here of wine. So you have red, you have white, and you have rosé. Okay, so you have red cells, you have white cells, and you have rosé cells, or as we call them, platelets. So very simply, red cells are just little red trucks that carry oxygen. That's all they do. You breathe in into your lungs, and all that air comes into your lungs. These little red cells, they come, they pick it up like a truck, pick up that oxygen, go deliver them to the tissues, your brain, your the rest of your body that needs it, drops it off, comes back for more. That's all red cells do. As I always say, I've offended every hematologist in the world right now, and that's okay. But I mean, it is the most important organ, obviously, right? The blood.
Yeah.
Okay, this means yes. All right, so you agree with me, right? Like the heart, it's just a pump, useless without blood. The kidney, a filter, useless without blood, right? So blood really, the life of the flesh is in the blood, right? I'm even quoting scripture now. All right, so point being is you got these red cells that carry oxygen. White cells, which we'll talk a lot about this weekend, are your soldier cells, as it were. They are what protects you, your immune system. Interestingly, we have 5 kinds of white cells, much like we have 5 major branches of the military. And these cells protect you, and they circulate in the blood to go and defend. So if I get stung by a bee, or I don't want to get too personal with some of our crowd here, but if I get stung by a scorpion at an IMF meeting, where's Mike? Those white cells will rush to that area and try and block off and protect you. The rosé cells, or the platelets, are little cells that help you clot. So if I were to cut myself, the first thing that gets there are the platelets. I think of them as like the ambulance cells. They get there first, they plug up the hole, as it were, and then they make a phone call to what are called factors, which form a strong blood clot. When people have hemophilia, for example, they have issues with their factors not being able to form a strong blood clot. So these 3 cells, the white, the red, the white, and the rosé, are what circulate in your blood, and they're all made in the factory of your blood, right? So if I want to know how good a factory is working, like a car factory, if there was a car factory down the street, we would say, okay, let's see how good the car factory is working. I could look at just the cars that have come off the assembly line. That tells me quite a bit about what's going on in the factory. But if I really want to understand the factory, the metal, the rubber, the working conditions, I need to go inside. And the bone marrow is the factory of our blood. And we go into the bone marrow, we see all this machinery that makes the white, red, and the rosé, that makes all these things that come out of it. And in particular, there's one small little area of the factory called the plasma cell. It's a very small part of it, normally 1 to 2% of the whole factory. I don't know if it was like a big car factory, it might be the section that makes steering wheels, right? Really small, very important, but very small. And these are called plasma cells. And I'll stop here in a second, Teresa, but these plasma cells, as you've all come to learn, are so important to life because the plasma cells are charged with making the proteins or the antibodies that fight off infection, right? You know, we love to use words that patients don't understand in medicine, right? That's how we do it, right? That's what they teach us for like 20 years in med school, right?
And when patients start to catch on, then we do it in an alphabet, an acronym, just so it's even more confusing.
And so we don't call them proteins or necessarily antibodies, we call them immunoglobulins, which just means immune proteins. And so these immunoglobulins, or these proteins, are the things that help you fight off infections. Myeloma is a cancer of the plasma cell. And again, what is cancer in its essence? I always say 3 words: identical, uncontrolled growth. Identical, uncontrolled growth. It's easier to conceive of a piece of lung tissue or breast tissue or colon tissue, but it's the same principle. So these plasma cells now start growing, and instead of making good antibodies, good immunoglobulins that fight off infection, they make bad antibodies or bad immunoglobulins that can start to attack you.
But if we have a whole bunch of these plasma cells, these immunoglobulins, these antibodies, shouldn't that be good for us and be able to protect us from infection?
You think it would, but these are different plasma cells. They're plasma cells that have gone off the rails a bit. They're a little bit gone rogue, and that's what cancer does, right? So breast tissue that is cancerous is not normal breast tissue. Lung tissue that becomes cancerous is not good lung tissue. So same with these plasma cells. So when we have normally functioning plasma cells, we say they make what we call polyclonal antibodies, which means poly means many or several different shapes and sizes that can fight off COVID and tetanus and measles, mumps, rubella, all the things that we get vaccinated for and that we've been exposed to. In myeloma, they now become monoclonal. What was our definition of cancer? Identical, uncontrolled growth. So it's the identical piece that becomes important here. And so now these plasma cells are producing these little Dr. Evil's mini-me's, right, of all the identical little cells that now produce these antibodies that can damage the body.
Okay, so if I have one of these clones, these monoclonal proteins, in my body, in my blood somewhere, do I have myeloma?
Now that's a great question, Teresa. If only you had a slide that can demonstrate that there are actually 3 phases. So again, not trying to make light of it. So remember earlier we said myeloma is relatively rare cancer, 1 to 2% of all cancers. On the other hand, the precursor to myeloma is incredibly common. In fact, having a little amount, a little schmutz of these abnormal cells is incredibly common. 5% of people over the age of 40, if I go test them today, I can find a small amount of this monoclonal protein. 5% of people over the age of 40 don't have myeloma. So we've had to make this distinction between, do you have just this tiny little bit of it? Almost like someone may have a very small mole. It's not skin cancer. It has the potential to become skin cancer, but it's not. We don't call every one of those benign moles melanoma or skin cancer. We can't call everyone that's got this little abnormal protein truly myeloma. So we have these 3 categories, and our big study in Iceland actually has been helping us understand this even better. And the 3 categories, as you see them here, are something called MGUS, or monoclonal gammopathy of undetermined significance. That was coined by our
he's channeling Robert Kyle.
Yeah, Dr. Bob Kyle, one of the grandfathers of myeloma. And basically this term is designed to say, if we test your blood and we find this little bit of protein, but it's not at a high level and it's not damaging the body in any way, you have MGUS. At the other extreme, if people have this bad protein and it's causing damage, the classic crab criteria that we'll come to in a moment, then you have myeloma. And then there's this area in between where people have more than the little schmutz, but not enough to have true myeloma. That little intermediate area is what we call smoldering multiple myeloma. As you can see, we define it by, if we do a bone marrow, how many plasma cells there are in the bone. Remember, normal was only 1 to 2%. And we look for other features, but there is a risk of going from MGUS to smoldering and from smoldering to active myeloma. The majority of people with MGUS in their whole lives will not develop myeloma. The vast majority do not, but there is a subset that do, and this is part of the work and the research that we do to try and understand it, so that ultimately, not only can we catch it early, I'd love to prevent it. Right? I'm working myself out of a job. That's the goal, right? Is to be able to prevent it.
Well, we should maybe think of putting Goldilocks on the screen here.
Yeah.
Not too much, not too little.
Not too little.
But do I need to actually break a bone or to go into renal failure before I start treatment for myeloma?
This is what made myeloma such a weird cancer for so many years, is that we said because of this prevalence of MGUS, we said, basically you can't define someone with myeloma until they have this so-called CRAB criteria. Their calcium is elevated, their renal or their kidneys have been damaged, they have anemia or a low red blood cell count, not enough red wine. I don't mean that literally. And B, that their bones are affected, right? For complicated reasons, these bad proteins like to attack your bone. They come from cells that are within the bone, but they themselves can also attack the bone. So for many years we said, you don't have myeloma until you have one of these CRAB criteria. But the reality is different than most cancers, because we typically define cancer by what we call the histology of what it looks like under the microscope. But it looks the same under the microscope. It was really just about the amount of it. And we don't want to wait until someone breaks a bone to say that they should have treatment for their myeloma. So the analogy I always give, Teresa, is, I'm a runner, although Sylvia, wherever she is making me cycle across Iceland. We're going to hear about that recently. So my backside has been getting used to sitting on a bike for hours a day, which is lovely. Anyway, I love my Peloton. Anyway, if I'm a runner, I like to run, and if I'm running towards a cliff, hopefully Teresa will catch me before I fall off the cliff, right? Before a patient develops CRAB symptoms, we want to catch their disease early, right? And so we've also noted that there are other things that maybe you haven't quite hit the cliff yet, but if you have these things, and now they're called SLIM or SLIM CRAB, S standing for 60%.
Somebody brilliant must have come up with this.
Yeah, whoever came up with that acronym is absolutely brilliant. Okay, no. 60% plasma cells. The Li or light chain means when we look at those light chains, we're going to talk in a moment about how these bad proteins are both heavy and light chains. If the light chains are really high, it tells us that the kidney could be damaged very soon. Or if when we do an MRI and we look at the bone marrow, we see a certain kind of image that tells us that the disease is growing quickly. So what we've done now is, instead of saying you have to wait until this damage occurs, if you're getting close to the cliff, then it's time to catch you. But this is a hot area of work and research and understanding. I don't want to treat 5% of the planet with chemotherapy, but I don't want to wait until someone is heavily damaged. We want to catch people in the right place. And we've learned, as you'll hear from me tomorrow, that sadly there are certain individuals who are at much higher risk of a delayed diagnosis. I bet you almost every myeloma patient in this room could share with me a story of how long it took them to get the diagnosis made. The average person sees their primary care provider 3 times with signs and symptoms consistent with myeloma before the diagnosis is made. That's even longer if you're African American or Latino American, for lots of different reasons. But every individual patient is different. We want to shorten that time to diagnosis. And whether that's going to be through a screening strategy, we're not sure yet. Whether it's raising great awareness of understanding within the primary care world of what tests to order and when to order them. These are the kinds of things that we're working on.
Well, and that's a question that comes up so often is, how is this not found sooner? Why were the blood tests that they were doing not showing that I had myeloma? Why is that? Why does it take a while?
Yeah, it often takes a while because these tests that have to look for this unusual protein in the blood, it's just not part of our usual blood testing because myeloma is not that common, right? So until we can prove that we should be doing it en masse in millions and millions of people, we don't naturally test for it. The other reason is that the signs and symptoms that people present with myeloma are often very vague and could be something else. I mean, the top 3 signs and symptoms of myeloma are bone pain, fatigue, and a low hemoglobin or anemia. And there's 100 other things that can cause those 3 before myeloma on the list. So that's why we struggle with making the diagnosis. But when we do, we look at those basic blood tests that are typically done, that looks at the red, white, and the rosé, what we call the CBC, the chemistry of our blood that also captures things like the calcium level and the kidney function as we've described. And then we go into the specialized testing that some of you unfortunately have become experts in now, or your serum protein electrophoresis, which just looks at all the proteins in your blood and tries to identify if any of those monoclonal ones are there. And then the free light chain assay, because these monoclonal proteins are shaped kind of like a Y, but the short arms of the Y, parts of them can break off, what we call light chains. And about 20% of myeloma patients only have light chain myeloma, so we have to look for both the light chains and the heavy chains. And sometimes we even have to look in the urine, because although the vast majority of patients can have their myeloma diagnosed and followed in their blood, there are some patients that we can only find that abnormal protein in their urine.
And I suspect we have to do some imaging.
Absolutely. So when we talk about bone disease in the old days, we used to do a skeletal survey, or a good Canadian boy that I am, we were trained to call it skeletal survey. And those were just plain x-rays. Well, those are helpful if someone unfortunately has a lot of bone disease, we can find problems with them. But now we've learned to do much more sophisticated imaging to catch much more subtle changes to the bone. So we typically do what's called a CT scan, or a whole body low-dose CT scan, or a PET scan, or even an MRI, because we want to look for any of the damage that's caused. That's what's going to make that big distinction between being MGUS or smoldering and true active myeloma, if there's evidence of bone involvement. And so we can, as you can see from the pictures here, see unfortunately the bone can be affected in lots of ways. Sometimes it's just the thinning of the bone, but sometimes it leads to a fracture. And one of the most common areas, unfortunately, are in our the vertebral column. And so we'll see patients like in this picture where there could be actually a broken body there.
And one of the favorite tests that people talk about is that bone marrow biopsy. Why is this so important? What do they do with this?
I wish we could stop doing bone marrows. And I think one of our research projects at the IMF actually is looking at reducing the frequency of bone marrow testing by being able to look for subtle changes in the blood. But going back to the analogy I gave earlier of the factory, you know, looking at those cars that have come off the assembly line tells me a lot about the factory, but it doesn't tell me everything. There are times that we simply need to be inside the factory. That's where the plasma cells live. Very occasionally, plasma cells can escape the bone marrow. They're not supposed to, but they can. There is this phenomenon called plasma cell leukemia, which is basically just a very extreme version of myeloma, where those plasma cells learn to live on their own. They don't need the bone marrow anymore. They don't need, you know, the supportive environment of the bone marrow. They can go off on their own. But we often do have to get those tests, do the test to get to the bone marrow. When we do get it, we're really looking for two major things. One, what percentage of plasma cells are there in that bone marrow? Because remember, by definition, myeloma is over 10%. There can be the occasional patient has less than 10, but that's for another day's discussion. And then secondly, not all plasma cells are the same. Not all cancer cells are the same. So one of the ways that we can distinguish them is by their, what we call cytogenetics. Now, these aren't the genes that you have that you would pass on to your children, right? These are the genes that have been mutated in those plasma cells that have caused cancer. That's what we think more often than not causes cancer, is the cell which is designed to live for a while and die off goes through some kind of mutation and it lives forever, right? That's what cancer is in a sense. It's that identical uncontrolled growth that we described that's sort of immortalized. And so in myeloma in particular, we can look for different genes that we think have been affected. And so you may remember that you get, you know, half of your chromosomes from your mother and half of your chromosomes from your father. So you've got 2 copies of each of your chromosomes. And we know that there are, on these chromosomes are kind of like codes for genes that actually enact the things that happen in our body. And so we can look for certain chromosomal changes that we know can predict, does someone have more aggressive myeloma or less aggressive myeloma, or simply divided, we often call it standard risk myeloma and high risk myeloma. Now, they're not perfect. We know that these different studies can predict and say, okay, someone has these, as you can see from the diagram, high-risk cytogenetic features. So they have a 17p deletion, or they have a translocation 1416, or they have a gain of 1q. I know these look like funny letters and words to some of you, but those reflect the chromosome number. So if you have a 1q addition, it means the q arm of your chromosome 1. So chromosomes are built like a sort of X-shaped, at least how we view them, and they all have what's called a P arm and a Q arm. That's where that expression comes from, mind your P's and Q's. Like, don't talk about my chromosomes that way, you know? Who said you can talk about my chromosomes, Deb? Like, stay away from my chromosomes. No.
You're showing your hematology geekness.
I know, I'm such a nerd, right? I'm sorry. I can win Trivial Pursuit games with you, so be careful. But anyway, so the P arm is affected, or in some cases it's the Q arm, or sometimes it's just one little gene. When you see the T letter, the translocation, it just means that one piece of a chromosome that's meant to be over here and another that's meant to be over there get together. So translocation 414 means a little piece of 4 goes to visit number 14 at their house, and they have a little party together, but unfortunately that creates a scenario that can give the cell immortality and allow it to be more cancerous. And so that's how we make that distinction. And I'm always cautious when I describe this, because I don't want people to think if you've been given a high-risk cytogenetic diagnosis that it's a death sentence, right? We thankfully are doing so much better in treating myeloma, but about 25% of patients will have high-risk myeloma and about 75% will have standard risk.
So you talk about risk. We also know about staging. For people that are here, what would you say is most significant in pulling all of this together and understanding the staging concepts and the risk stratification?
Yeah. So if you get diagnosed with any cancer, one of the first things that your family, your friends are going to say is, well, what stage is it, right? Because we're sort of built on this solid tumor model where whether it's breast cancer or lung cancer or colon cancer, if it's confined to one area, it tends to be more treatable, but as it's spread, it goes to higher stage. So, you know, stage 2 breast cancer means it's gone a certain distance. Stage 3 distance, stage 4 means it's metastatic and has spread to other places. Myeloma is a bit more complicated because we're liquid to begin with, right? So we're circulating everywhere. So it's not so much a proximity distance. So over the years, we've developed different staging systems, and it's no wonder that in lymphoma and leukemia and myeloma, the 3 blood cancers, we keep changing our staging systems because it's just not an easy thing to do. The solid tumor doctors look at us and say, we've had the same staging system for 50 years. You guys keep changing yours every couple of years. Again, that's not to make light of it, but it's just to say it's complicated because we've come to learn that it's not so much, you know, as it's spread further, because these are diseases that just naturally flow, it's a question of those cytogenetics. And as we study the cytogenetics better, ever since the Human Genome Project, we can now understand the disease better. So we have what's called the International Staging System. And then there was the Revised International Staging System. Then there was the Revised Again staging system. Let me tell you, I'm sure there's going to be an R3 and an R4. Like, I would be less concerned. Yeah, exactly. It's never going to stop. So I would be less concerned about the formal stage as much as what are your cytogenetics in terms of have they put you in the standard risk bucket or the high risk bucket? And that's generally how we look at it because that does have implications for treatment.
All right, so as you mentioned treatment, now we figured out with all the tests that I have a newly diagnosed myeloma, it requires treatment or recommended for treatment. I pretty much just have to have a couple cycles of chemo and I'm done, right?
I wish that were the case. That's our goal. Remember, I'm trying to work myself out of a job. But right now, when people come to be treated, we still generally divide people into these 2 categories. Are you eligible for transplant or are you not eligible for transplant? And that's based on the phenomenon that a so-called transplant is a good thing for myeloma. Now that's being questioned and you'll hear about that. Dr. Loniel will talk about it, we'll discuss it. I'm sure it'll come up in the Q&A with these new therapies like CAR T-cell therapy and so on. Are we gonna be replacing stem cell transplant? It's a little early to tell. But in general, we make that distinction. Either way, people get some kind of initial therapy, and based on my first hot topic today, what was the first hot topic? Anybody?
More is better.
More is better. Okay, thank you. Somebody was listening. It's like, but no, we talked about how we're often now using 4 drug combinations off the start. Often it's the same whether you're going to transplant or not, actually. But at some point, the goal there is to what we call induce a remission, or it's called induction therapy, because the idea is to get the disease down And then that's followed by what we call consolidation therapy, which is basically to keep the disease down. And then there's maintenance therapy, which is to maintain the remission over a long period of time. Induction and consolidation is all about depth of response. Maintenance is all about duration of response, which is why induction and consolidation tend to be intense things, because we really want to shrink down this disease. But maintenance therapy, it's so important that it's gentle on you. Some of us were chatting about maintenance therapy at the break, because that's what's there for the long term. And as Jellic shared with us, I mean, our goal is to allow people to live life to the fullest, right? And so maintenance therapy should not be harsh on your quality of life. And so that's where we have all these different terms. The last thing I'll say about transplant, for those who aren't familiar with it, you'll be hearing more from Dr. Loniel tomorrow if you haven't heard much about it. Transplant is basically one big whopping dose of chemotherapy. That's all it really is. It's just trying to add another layer of damage to those cancer cells. But because it's so intense, it hits a lot of your good bone marrow. So prior to giving it to you, we collect from you what are called stem cells, or cells that can grow a new bone marrow, like if you will, like seeds that could grow a new bone marrow. So we take the seeds or the stem cells from you, we give you that big whopping dose of chemo, then we give you your stem cells back to regrow the marrow. It's not curative, but we know that it can help put the disease into remission for longer.
In your wine analogy, that'd be like the tequila.
If you want to have some tequila, you can have some tequila.
A heavy dose. So when we think
Apparently,
about,
we are not tequila lovers here. Yes.
when we think about the different treatment options, I mean, Robin started to allude to this as she was doing the overview of the myeloma.org website. But we have a lot of treatment now available.
Amazing. I mean, when I started in myeloma over 20 years ago, there were maybe 3 names on this slide and the next one total. And now look at all the drugs we have. This is not a remedial reading course. I'm not going to read them all for you. And as you saw from the QR code, you can download these slides yourselves. But it's remarkable how many different classes of drugs that we've had. And as was explained before, you know, a drug has a so-called generic name, a medical name that we give it, and then it gets a trade name once it reaches a level of approval. And so we have all these different classes of drugs. And historically, we've worked with the IMiDs, or the immunomodulatory drugs like Revlimid and Pomalyst, and the proteasome inhibitors, and then added steroids to it. So someone was asking me at the break, you know, steroids are back when I started myeloma, often that's all we gave patients. We didn't have access to anything. We would just give steroids. So steroids have a direct anti-myeloma effect. They also reduce the risk of getting a reaction. They can also reduce nausea and reduce pain. So steroids are the drugs that we love, but we also hate it. Because for any of you who have been on steroids, and now I can look at your partners, you might be affected by it, right? Like it affects your ability to sleep, it affects your grumpy factor, it affects your blood sugar, your blood pressure, it does all sorts of badness. So later on, at some point this weekend, we'll talk about the movement that we've created, the new hashtag #DownWithDex, where we're really trying to reduce the amount of DEX. I think of DEX like the booster rockets on the shuttle. Really helpful for the first few cycles, but then we need to taper it down because it causes a lot of damage with time. But now more recently, we've added monoclonal antibodies. We've added XPO1 inhibitors like selinexor, and we've added these others that you're going to hear a lot about this weekend. In particular, I've already highlighted belantamab, CAR T-cell therapy, and bispecific antibodies. And I shared with you earlier a little bit about how those work, and I think we've got a picture or two to help describe those later. But in essence, CAR T-cell therapy is different than stem cell transplant. Stem cell transplant, I take your seed cells or stem cells, give you the chemo, then give those to just grow your bone marrow back. CAR T-cell therapy, the collection may be similar, but now we collect T cells, or these soldier cells that can attack myeloma, and in the lab we manufacture them in such a way that they're going to attack your myeloma, and miraculously we multiply them in the lab. And we actually even give them back to you knowing that they're going to multiply more when we give them back to you. And that's what's called CAR T, or chimeric antigen receptor T cell therapy.
So
there's a lot more to come.
We get the therapy started. How do we know it's working?
Right, so with any cancer, you want to see it shrink, right? If someone has lung cancer and it's 10 centimeters wide, you want to see that number go down. We don't have a simple tumor that we're measuring in myeloma, so we measure what was ever measurable at the start. Was it the M spike, or that monoclonal protein we talked about? Was it the light chain level? We also look at the percent plasma cells in your bone marrow. We may also look at the imaging. I've often said in my clinic, myeloma is kind of like a crime scene. There's no one piece of evidence that tells you the whole story. You've got to look at the whole thing together. And over time, we want to see all of those measures go in a direction that gives people so-called remission. And so we have depths of that remission. So typically, we consider someone a responder if whatever measure of myeloma gets cut by half. That's called a partial response or a partial remission. If it goes down by 90%, which is a huge drop, that's a very good partial remission. If it goes down by 100%, it's a complete response. Doesn't mean cure, but it's 100%. And then we even have riders on that to decide how we define complete response, because there's something called stringent complete response, et cetera. But then unfortunately, we know that that's not curative, because at some point the disease will come back, but we want to get people as deep as possible. That's why you're going to also hear this weekend about MRD, or minimal residual disease, which is where we barely find any bits of myeloma left. But sadly, even when people get into MRD negativity, there will likely come a time where the disease comes back.
And that, I guess, is the next question. How do we know when we need a new treatment?
Yeah, and it's challenging, because just because the number appears again or starts to climb, we don't necessarily jump on it right away, because these numbers are fickle. We've all seen numbers blip back and forth, and going back to the same analogy, I'm running towards a cliff. I don't want to wait until my patient gets really sick again. I don't want that M spike to go up to where it was before and them to start breaking bones and damaging their kidney, so we want to intervene early. So that's why we often call it a biochemical progression, or asymptomatic. Someone would, hey doc, I feel well, why do you want to start treatment? That's why you get blood tests when you still feel well, because we want to track that protein and see if it's climbing. And then unfortunately, when it reaches a level that is truly climbing, we tend to want to intervene.
So how do we attack that relapse?
So this one slide, I know that it looks like alphabet soup to many of you, but one of the things that I said right off the start, we talked to Hot Topics, is coming at the myeloma in different ways is guided by the great research that we've done in the myeloma community across the whole world in understanding myeloma. One of the things we've understood with myeloma is all of our cells, actually, in particular myeloma cells, have these things that stick out of them. Sometimes we don't even really know what they do, but we know it's something we can grab onto. And so these drugs that we've developed, the antibodies that tag onto it, the CAR T-cell therapies where the T-cell hooks onto it, the bispecific antibodies as prescribed that grabs onto the myeloma cell and to a local T-cell, they all have to find a target on the myeloma cell. And for many years, we were very familiar with two targets, CD38 and something called SLAM-F7, or used to be called CS1. But more recently, we've found 3 new targets on myeloma cells that a lot of these drugs use. One's called BCMA, or B-cell maturation antigen, and the other is FCRH5, another called GPRC5D. Again, remember, this is just to give you an overview. A lot more detail is going to be coming over the next day around these things, but these now have served as targets for the different therapies that we have as we try to attack the myeloma cell. Because these myeloma cells are smart. You know, I attack the CD38 antigen, I grab onto it, eventually the myeloma figures it out. And the CD38 antigen, or antigen is just another word for target on the cell, when that CD38 disappears, now I can't grab it anymore, right? And so I need to come at it in a different way. And then that target runs thin, and then I need to come a different way. This is how the cancer evolves and begins to evade therapy.
And we've evolved. Look at where we're at, where we're going.
This is my favorite slide. I update it now literally every month, because there are just so many drugs that we have in myeloma. And it's not a perfect list. It continues to grow, but we've gone from 1, 2, 3 drugs in myeloma to over 20 in the last 20 years. And using them in the right combination in the right way, I think is going to help us keep patients in remission for much, much longer.
Now I'm going to ask you the million-dollar question. What about cure? What about cure versus control? How do we define cure?
Yeah, it's a challenging way to think about it, but really important, right? So historically, we used to say there are two kind of camps of thinking in myeloma. Are you in the cure camp or are you the control camp, right? If you're in the cure camp, right, let's just completely devastate this disease. Let's give someone as much treatment as we can. This was exemplified in Arkansas that developed a program called the Total Therapy Program. They would give people 3 transplants and every drug that they've known. They would just try to whoop this disease as best it could. And for some people, it may haven't acted a cure, but for a lot of people, it gave a lot of toxicity, a lot of side effects. The control camp says, no, myeloma is kind of like high blood pressure. We're never going to cure it, we'll just control it. Let's just give the minimal amount of drug to keep it in check. Well, the reality is both extremes are not the way to go. It's somewhere in the middle. We're probably leaning a little bit more towards the cure side now. But what is cure to you may be defined differently by someone else. I think of cure as being when you treat someone and they never have to think about the disease again. And we're not quite there yet. Maybe just taking a pill like you do for high blood pressure is going to be enough for the rest of your life. But we do see a much larger fraction of patients living longer. When I started myeloma, the average survival of patients was between 1 and 2 years. Now the average survival is over a decade. And for many, as we've already seen today, it can be considerably longer.
Yes.
That being said, I do also just want to be realistic that there's still, sadly, I had a patient who died less than 6 months after his diagnosis. So there are still forms of myeloma that are extremely challenging to deal with. But overall, that curve that you're seeing, meaning how many people are living 5 years and beyond continues to grow, and I think it'll continue to get better.
All right. Well, I think we've picked your brain enough for this moment. We're going to come back and do that again later. But I think Dr. Joe did a great job answering these questions. And the answers to many of these questions, not quite as eloquent, are available in a lot of the publications. So thank you.